Hello, everyone. Welcome to another edition of Brain Trust, Conversations in Psychopharmacology. I'm Dr. Joe Goldberg, clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai. It's a pleasure to welcome you to another edition of our ongoing program series, chatting conversationally with eminent clinical psychopharmacologists on topics that should matter most to you as far as unresolved issues, controversies, things that are top of mind, or if they're not, they probably should be, and a chance to sort of eavesdrop into the thinking of our colleagues who have, well, knowledge and expertise in these very important areas. So I'm really thrilled to welcome our guest today, Dr. Michael Gitlin. Michael is Distinguished Professor of Clinical Psychiatry at the UCLA School of Medicine. He's currently Director of the Adult Division in the Department of Psychiatry and Medical Director of the Neuropsychiatric Behavioral Health Services and Director of the Mood Disorders Clinic at UCLA. He has an extensive CV, a well-published, well-represented presence in the mood disorders space, someone whom I would call one of the wisest clinicians. I don't say this about everybody, Michael, but one of the wisest clinicians I know, and I'll share this when I have a clinical question about something and I'm just not sure, and I'm not looking for a textbook neurotransmitter answer, but something a little more practical. I call Michael, and Michael's very responsive. So I'm really thrilled to have you here with us today, Michael. Welcome.
Thank you. I'm honored to be here, and thank you for those lovely and kind words.
And true. And our topic today is one that I think a lot of our listeners and viewers are going to find interesting, which is the issue of the psychopharmacology of personality disorders, a topic that you've thought about, written about. You can think of no one better to sort of tackle this tough area. So let's delve in. I'm going to start out by just asking you, is there any kind of an oxymoron between the notion of psychopharmacology and personality disorders? How do those two things come together? Or are they so fundamentally different that we just force them together in ways that are unnatural?
Yeah, they certainly are not as natural, the relationship between treating personality disorders and the use of medicines, as it would be for classic symptom-based disorders, as we used to talk about them, axis 1 versus axis 2. Because when we describe symptom-based disorders, mood disorders, anxiety disorders, psychotic disorders, we have symptoms, we have time frames, and it fits the medical model. It's the way DSM-3 and all subsequent DSMs have been written. But personalities, the other issue about symptom-based disorders is the DSM is categorical, meaning there are allegedly boundaries around all of the disorders. 5 of 9 criteria gets you a depression. 4 of 9, you're not a major depression. The problem is all of psychopathology, but most of all, certainly personality pathology, is dimensional, not categorical. To say that our descriptions are arbitrary is really an understatement. So personality disorders don't even fit very well in the DSM, let alone about medications. The other issue is personality disorders are by definition, like personality, enduring, pervasive, and stable. It's not, you don't talk about a personality disorder beginning in February and ending in June, like you can, an episode of schizophrenia, an episode of mania, an episode of depression. So that also has created problems. Nonetheless, from the very beginning, we all had as clinicians, we had the sense that there was something about some personality disorders, mostly cluster B, mostly borderline personality disorder, where it felt that even though the expression of the disorder was interpersonal, intrapersonal, fit in the language of personality, there was something biological, some biological underpinning to the problems these people had. So from early on, we were prescribing medications in really a not very thoughtful way because A, we had no database, and B, we didn't have a good hypothesis as to what medications did for personality pathology, but we prescribed them all the time. And that also, a further implication is polypharmacy is the rule rather than the exception in that group, despite the fact that we all tell ourselves, no, you shouldn't do that. We all do it all the time. And, on one end, you can look at it and say, well, that means all these clinicians are bozos. They're really sloppy about what they're doing. What's much more likely, rather than, I mean, maybe some of us oppose those. What's more likely, however, is that what you're looking at is desperation.
Desperate. I was going to use that word. I was going
to. And that's the right word.
Yeah.
Because we need to do something to help these people. They're difficult to help. And so we just throw things, sometimes in a not very discriminating manner, but the goal is really to help people feel better, because we don't know how to do that.
You want to alleviate suffering. I mean, nobody in our business goes into this saying, yeah, you're suffering, but so what? I mean, it pulls to our natural instinct, but I guess nowadays it falls back on our natural instinct being tangibly, what can I do pharmacologically?
So, yeah, and I think the first thing to acknowledge is doesn't have to be this or that. It's probably this and that are probably the optimal approaches. I mean, are there some patients with personality pathology who could get dramatically better with pharmacotherapy alone? Yeah, maybe. But it's much more likely, it would seem to me clinically, that the combination of the therapy and the medications is going to be optimal. No different than you'd see with classic symptom-based disorders. So it's just true with depression. There's a whole literature on bipolar disorder and adjunctive psychotherapy, not instead of, but in addition to, showing that the two clearly are associated with decreased relapse rates compared to pharmacotherapy alone. And when you prescribe medications for personality disorders, the question is, well, conceptually, what are you doing? Which was implied in your question. You could say, well, do we really have anti-borderline pills? As you say it, one smiles even just to think of that, because it feels so absurd. And no, we don't have anti-borderline medications. You could also think that because most patients with serious personality pathology have a lot of associated axis 1 disorders, depression, anxiety, bipolar disorder, substance abuse, etc., could it be that all you're really doing with meds is treating the comorbid axis 1 disorders? So since we know depression is incredibly common in patients with borderline personality, well, if you're using any mood agent, whether it's antidepressants or mood stabilizers or whatever, if they work, really, are you just really treating associated symptom-based disorders? Well, if that's true, that's the end of our discussion. But it's not true, so there is more to discuss. What is most likely is when you give a medication that helps somebody with their personality pathology, and this is very anti-DSM, really treating not the disorder, but you're treating symptom complexes or behavioral dimensions of psychopathology is the technical term. So I don't know how to treat borderline personality disorder, but do I know how to treat impulsive aggressive behavior? Do I know how to treat affective liability? The answer to the last two is yes. And since those are the core symptom components of the personality pathology, that's what you're doing. So instead of saying, do I know how to treat borderline personality disorder with medicines, what we should do is take a step back, say, what are the symptom complexes that dominate the features of that personality disorder? And then say, do I know how to treat that? Because I do know how to treat affective liability, and I know how to treat impulsive aggressive behavior. And if I do that, the borderlineness will get better. And that strikes me as what we're doing.
So should we use different language? We're sort of steeped in, I guess, what we used to call axis 1, target symptoms. And instead of things like sleep, energy, concentration, appetite, maybe if we're going to say, let's talk about the pharmacotherapy of a personality disorder in this dimensional way that you're describing. And should we say things like, I'm going to try to improve your cognitive rigidity, or your exquisite sensitivity to interpersonal affronts, or improve your resilience or your capacity for reflective delay when something happens? I mean, we don't really use that language, do we? I mean, some of us might, but
no, we don't use that language. But you're absolutely right. That's what I'm suggesting, is that we reconsider that. And the problem is, this is so antithetical to the DSM approach, where treatments are linked to diagnoses, not to symptom complexes. But that doesn't work very well for
Yeah.
personalities. Personalities live in a somewhat different world. And because of that, I agree with what you said.
Now, let me play devil's advocate because I like to do that kind of thing. So there's something called, I guess, narrative theory out there, which is a way of describing psychiatric conditions as ego dystonic things. Like, that's not you, that's your depression. That's not you, that's your psychosis, and a kind of a divorcing of you as a person from this entity as if it was an infectious disease. And when somebody's hopeless, well, that's your depression talking. We use that language to I think, frame things for patients. It's a little tricky, if not disingenuous, to kind of say, well, that's not you, that's your personality disorder.
Yeah.
Or to frame it as in this narrative theory to say, well, you get really angry when somebody is insensitive to you. We can try a medicine and see if that'll tame this. But in terms of narrative theory, are we almost saying to the person, I don't know, I'm not trying to write the right phrasing this, you are the victim of an illness. And so we're going to treat it. And then it invites questions from the patient, like, my meds aren't working. I got really angry the other day. My meds aren't working. Does it encourage a kind of a passivity that could go at odds with the psychotherapeutic goals of accountability?
Yeah, it could do that if it goes badly. I agree with you. But I would imagine that many, many years ago, you read Listening to Prozac, Peter Kramer's book, as well as I did, in which he really meditated on the idea of what does it mean if you give somebody a medicine, for him it was SSRIs,
Yeah.
and you change their capacity to deal with rejection, one of the examples you just used, Joe. And suddenly, when things don't go well interpersonally, instead of falling apart, you just feel bad, a more normative response to rejection. And you say, oh, this is the person I always thought I would be, except I wasn't. And Kramer talks a lot about that. And I think it's a tricky business. I agree with you. It can be used as, I don't have to do any psychological work. Just give me the right pill. And, I'll suddenly go from this completely chaotic person to a third grade teacher or an accountant. But then that's where the psychotherapy work comes in, is to really being able to, on one hand, own the personality traits and at the same time say, but maybe they could be ameliorated somewhat with pharmacotherapy.
Now, Peter Kramer's book, which I agree was quite the groundbreaker when Prozac came out, didn't get into things like treatment-resistant depression. In fact, back at the dawn of the SSRIs, right, we reserved tricyclics and MAOIs for the worst of the worst. And so I think Kramer's notion was to say, there could be a lot of dysthymic disorder that's medication responsive. And up till now, because the side effects of our medicines have been so onerous, what happens if we actually use a medicine and lo and behold, there's a lot of even low-grade depression that is responsive. Dilemma, though, so you're saying before about polypharmacy and desperation. Fine, I've given you Prozac and Effexor and Pristiq and mirtazapine and atypical antipsychotics and augmentations, blah, 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 blah. And at what point, with all due respect to Peter Kramer, at what point does one say, wow, you've been on a lot of medicine, maybe you say this to yourself, been on a lot of medicines. This is just the most treatment-resistant depression. We need a nuclear antidepressant. Heck, in borderline personality disorder, as you know, there's double-blind studies saying ECT does not work as well for major depression in the presence of borderline personality disorder. So when do we need a bigger antidepressant weapon after many non-responses? And when do we say, I'm not sure we're going to make much headway on the biological treatment of your comorbid depression because there's something intrinsic about the personality disorder that meds just don't touch?
Or maybe they don't touch, or they just aren't as effective. As you said, for the ECT data, it's not like somebody who has ECT, who has depression and borderline personality, will never respond to ECT, but they have a lower response rate than those that don't have serious personality pathology. And there are some data showing that if you look at people who have comorbid depression and borderline personality, which, as you know, is incredibly common comorbidity, because again, with comorbidity, the idea of obsessing about what's primary and what's secondary is tricky business, it seems to me.
I like what you're saying about the comorbidity piece and the dualism as opposed to the hierarchical notion. If only this wasn't there, this would be different. And my thought here is substance use comorbidity with mood disorders. I've never in 30 plus years ever made a depression go away in someone who's got active, ongoing, meaningful substance use disorder. And it's always seemed to me we've got to treat both. And I can get you abstinent, but that's not going to guarantee.
What you're saying is that the way we need to think about those situations is that people have multiple primary disorders, even though each one will affect the treatment responsiveness of the other. And despite that, you treat them as two primary disorders, and you got to treat them independently with presumably separate modalities of treatment. Yeah, that sounds right.
Even, Mary Zanarini, who's done an awful lot of interesting work in borderline personality disorder and pharmacology. And I think people like Eric Hollander, who sort of talked about dimensions of psychopathology that one can improve. Can you leverage impulsive aggression with valproate? Can you leverage mood instability with lamotrigine? And it's not the same thing, obviously, as saying, okay, this is just a junior version of bipolar disorder or a junior version of a psychotic disorder. It's really, as you say, sort of pulling out a dimension and saying, can I extrapolate from the access to literature about this dimension and empirically try it? And I guess a lot then has to do with how you set it up for the patient. So it's not to say it's like amoxicillin for your strep throat. It's going to knock it all out, right?
Right. That's the naive approach. You may remember years and years and years ago, Akiskal wrote a book chapter in a book about borderline personality, in which he said, this is most ridiculous to even talk about this because borderline personality doesn't exist. It's just an atypical looking bipolar. I think is incorrect. I think there are not everything that goes up and down is bipolar disorder. And I think we need to make those distinctions because among misdiagnoses, as an example, is in both directions is borderline personality and either cyclothymic or bipolar 2 disorder, in which clinicians don't always do a thoughtful job of making the distinction. Obviously, you can have both. But, the Mark Zimmerman has some data on how frequently people with substance abuse are labeled bipolar, as an example, when they don't, because we're not really looking at the complications of different forms of affective liability, which can be due to drugs, can be due to personality pathology, etc.
We think about some of these personality disorders that may also skirt the boundaries of pharmacology, which is the word trauma. So I have colleagues, so do you, who don't believe that borderline personality disorder exists, but they don't think it's diminutive bipolar disorder. They think it's still proven otherwise post-traumatic stress disorder. And there is this
complex trauma.
What's that?
Complex
trauma. CPTSD. Thank you.
That's the way they see it.
Well, I got to say, there are people I've seen who I will put that down, I guess, in my ICD. It's not a DSM. But boy, this is someone who's had sustained, prolonged difficulties where they, report experiencing abuse, and there's this intense sense of victimization. And you start to wonder on a psychological level if they're almost, I hate to say, like, their symptoms have importance to them because it's like battle scars in a way of the injustices. I mean, to me, this is a real dilemma. If you're psychologically minded as a practitioner, and either through training or your day job, you've come to say, well, what med can I use, without stepping back and thinking about learning and behavior and adaptation to the environment and adversity in ways that may transcend some of the pharmacology. The same way you're not going to treat a salivating Pavlovian dog with an anticholinergic. You're going to have to decondition. You're going to have to decondition the stimuli.
Right, and as you know, there's evidence that early abuse and neglect as one form of trauma, it's not the only one, of course, can theoretically, you certainly can show this in primates, non-human primates, and there's a little evidence with humans, that with early abuse and neglect, you may alter, let's say, the HPA axis permanently. so that the person responds to stress in a biologically and symptomatically abnormal way later in life, which of course may alter their responsivity to pharmacotherapies, etc. So again, we need to get away from the dichotomy of, oh, this is psychological and complex trauma versus, oh, this is a depression or some sort of primary biological deficit that we need to treat with meds, because the two can be easily interrelated. So that would be my wariness. I think you also brought up, this is not specifically about personality pathology, but it's a very tricky issue when a patient comes in and says, I'm this way because I have complex trauma, because stuff happened to me early on that was terribly traumatic, and that's why I don't have good relationships, I can't work, I can't do blah, 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 blah. And the complex PTSD becomes not a diagnosis or a disorder, but an identity.
Ooh.
And it's a very tricky business if it's an identity and you want to help somebody get better, you're taking away their identity. And so it becomes very, very tricky. So how we deal with people who have truly traumatic pasts and now aren't doing well in their lives, but we want them to do better, not just to feel better, but function better. Because I think as psychiatrists, that's part of our job, is to help people lead more full lives, have relationships, have kind of a role function in their life, whether it's as a student, a parent, a lover, a worker, whatever. It becomes difficult.
Michael, you just said something so important. I got a little chill just now. I want to rephrase and reframe what you said. So rephrasing it, there are experiences people can have that are bothersome and troublesome to them and sources of distress and suffering, and yet they experience them as consistent with who they are as a person, that is their egosyntonic experiences. And a lot of what we do in mental health, I think, is to try to take these undesirable experiences people have and try to identify them as ego alien and ego dystonic and say, well, that's this is bad thing out there, so let's zap it with our treatment, whatever it may be. Your wisdom here, Michael, is saying, but you're talking about a part of you and how you see yourself. Who comes in and says, there's this thing about how I form attachments, about how I react emotionally to things that happen to me, and I don't like that quality. Can you zap it, or can you make it go away, rather than sort of a sense of an affront, like, this is me and who I am. You have a problem with it? It's a very, very delicate needle to thread, isn't it?
Indeed, right. And we have people in my mood clinic who come into the clinic and they say, well, I have bipolar disorder. And we do as much work as we can to look at their whole history and come to the conclusion that they're not bipolar. They have another form of affective liability, and try telling them that, trying to take the identity of being bipolar away from them, that is not a pleasant conversation. Because again, sometimes diagnoses become identities. And, I am bipolar as opposed to I'm a person with bipolar disorder is the way the linguistic distinction is made. But it's very real for some of our patients. And it is incredibly delicate to deal with that.
How do you thread that needle yourself, Michael? Share with our viewers your wisdom.
The answer is very, very slowly. The idea of just saying, look, I don't think you're bipolar because of this, this, and this, and it's more consistent with that and that never works. That's something that almost always requires true psychotherapy to deal with the meaning of identity. What does it mean to you? What would it mean to you if that identity was different? If you weren't bipolar, how would you see yourself in the world then? That's not something you can answer in an hour. That takes hard psychological work.
I've had the experience of saying to patients now and then, suppose I had the perfect medicine remedy for your mood problems. What would your life look like then? What would you see? Do you know what most people say to me?
But
I haven't got the faintest idea. I don't know. So use your imagination. Come on, boom. I've given you a PHQ-9. I've given you this rating scale. If those things were gone, what would your life look like? What would your aspirations? What would you want? And I tell you, people are dumbfounded. If you say to me, "Oh, you take away my arthritis, I can run the marathon. You take away my asthma, and I can walk a mile." I don't hear that when there's personality present because of this ego intimacy.
I agree with you 100%. And that's exactly what I was alluding to. What you're talking about is egosyntonic. That the vision is egosyntonic is, I was using the word identity.
Yeah.
I think it's the same concept.
Now, let me throw another twist on this topic, if I may. So in the world of mood disorders, as much as we're talking about treatment resistance and how personality disorders can sometimes be significant complicators of treating an axis 1 disorder, at the same time, when people like you and I do our clinical trials in mood disorders, we find in depression, there's a 30 to 40% placebo response rate. So what's my question here? Is there some clever way that a really smart practitioner could somehow leverage whatever goes into the placebo response? Maybe it has to do with imparting a sense of I care and I'm present and I'm listening, and you're sort of creating almost like a holding environment for someone, and I'm looking out for your well-being. And who's to say that when medicines are effective in the setting of a personality disorder, we're actually doing accidental psychotherapy because we're creating a kind of a holding environment?
No doubt about it. Look, if you're doing an RCT, you don't want placebo responses mess you up, because how are you going to show a difference if the placebo response is too high? As a clinician, you should massage every placebo factor in sight, whether it's, as you say, the holding environment. They come to a socially sanctioned healer. That already gets you a few steps up on the placebo response. It turns out just seeing people isn't as effective as giving them something like a pill, even if the pill is an inert placebo. The fact of taking the pill from a socially sanctioned healer already increases response rates. And you would imagine that relationships between the healer, us, and our patients would also enhance the placebo response rate.
It's also tangibly validating suffering, right? I mean, it's not saying there's nothing wrong with you, or you go work on this in psychotherapy. I've always thought that good psychopharmacologists who really understand the nonspecific ingredients of the placebo response get better results because they know what to say. We're not a vending machine just doling out the pills. We kind of know how to dole out the pills and how to validate suffering and how to say, you have suffered, and I'm here to try to make your suffering go away. I'm going to do everything that I can to take the best care of you that I can. Here, let's try this. Let's see what it can do, because I'm coming to you from a place of benevolence.
Mm-hmm. And hopefully the patient will perceive you as benevolent.
Yeah, well, that's the other conundrum with personality disorders, right? Is you can alienate, you can bite the hand that feeds you, or you could reject help. I think this is one of the problems, probably, that goes into polypharmacy. I would wager to guess a lot of our colleagues out there who are saying, "Oh, this is somebody with a personality disorder, and I really dread seeing them. I don't know what to do," are going at this in a very uphill battle kind of way. It's hard to muster the empathy when that happens.
Yes, I have nothing to say except yes, those are very difficult times on both sides of the chairs.
And for the seasoned veteran, or the one who wants to be, I dare say you could work with that. I mean, I'd hate to say, you have character pathology, I can't help you, goodbye. I mean, even if my approach is, let's call it pharmacologic in nature, if I'm a really good diagnostician and evaluator, I'm not just doing my DSM checklist kinds of things, but I have this sense of your attachment style and how you value or devalue other people and what you expect and you're feeling cared about and what your traits are. I dare say, maybe this is going to sound a little highfalutin, but I dare say you could deliver better pharmacotherapy than someone who just says, well, your PHQ is at 13, I guess we'll raise the dose, come back in a month.
Yeah, and first of all, again, I think that's entirely true, that the simplistic approaches work with simple problems, but there's nothing simple about treating complex personality pathology. So yes, you have to present it in a different way. The other problem you have, at least with patients with borderline personality, they split, all good or all bad. And if the fantasy is, oh, this doctor's going to give me a pill and all my relationships are going to get better, and this, well, that's obviously not going to happen. So part of what you do, if hopefully you do this thoughtfully and well, is before you start treating the patient with borderline personality, you work with them on identifying how would you know if the medication is going to be helpful. No, you're not suddenly going to get a PhD. What's going to happen is maybe you'll be able to call your therapist before you cut yourself instead of after. That's a therapeutic triumph.
Yeah.
Now, but the patient could say, yeah, but my relationship still stink, and I still have my legal problems and this and that. So you have to really help them understand what might get better. So you have an agreed upon, almost a personalized checklist, a rating scale, but it's not a formal rating scale. It's, if I'm going to give an anticonvulsant to somebody with marked impulsivity and aggressive behavior, what do I expect to get better? Not their whole lives, but maybe they get into fewer fights. Or maybe the fights are more gentle, or they can walk away when they recognize it. Again, trying to be personal and complex about what are the goals of treatment.
Oh, boy, you keep using these words. You just pulled them out of my head, Michael. First you did it with desperation. Now you did it with the goals of treatment. I've always admired palliative care doctors who the first thing they say is, what are the goals of treatment? Very first time I ever heard that when I was a med student, it's like, oh my God, that's exactly why I want to be a doctor. What are the goals of treatment? And I'm not the fairy godmother with the wand who's going to change your life.
Right.
But what is it you hope I can do? I love to ask, try to ask that question to patients. You have that experience? Like, what is it you're hoping that we're going to do with my pharmacological wand?
Yeah. And, if you're treating a classic major depression, that's pretty easy. You and the patient are probably going to very quickly come to the same set of goals of treatment. But with personality pathology, you may not. That's going to take more talking and more mutual understanding. The patient, what do they want to get better? And for us, what do we realistically think medications can do? So that they don't get better because the medication did what it was supposed to do, but they perceived it as not helpful because what they wanted was not realistic, was not what pharmacotherapy can manage.
Now, tell me this. Do you think that it's shady or wise to say, I'm going to meet with you, we can try medicine, see if they help, but I did read that Cochrane review. There is no evidence for pharmacotherapy in borderline personality disorder. I'm paraphrasing, but it wasn't even the usual Cochrane review that says, well, there's really no good high quality evidence. Whoever wrote this was just, oh boy, I wanted to give them Prozac. So in our own heads, yeah, you could say for randomized controlled trials, there is no anti-borderline medicine. But at the same time, to your point about goals of treatment, if I could improve your sleep, if I could reduce impulsive aggression, if I could help you be able to take 10 deep breaths when someone says something that's troublesome to you, that's not going to come up on a Xanarini rating scale. It's not going to register for an FDA registration trial. But if I, as a clinician, have identified those goals of treatment, what's wrong with saying, all right, we'll keep trying more medicines, but along the way, the real treatment is you're seeing me, and it's called the therapeutic alliance. But we're not going to call it that. Not out loud.
First of all, I think your cynical comment about Cochrane reviews is entirely correct. And if the two most recent papers written in journals, the Cochrane reviews being different, there's one in JAMA, one in Lancet. God knows why they were in two non-psychiatric journals, reviews on borderline personality disorder, and they both came out with the exact same conclusion that you just said, which is that pharmacotherapy does not change the outcome of borderline personality disorder treatment. And by and large, if you're going to use meds, use them one at a time and only briefly. Wow, that doesn't in any way comport with what I do with these patients myself. So you're right. I don't sit there and quote the results of the literature to patients when I see them, but the idea of saying, look, I think what you have, I know, is difficult to live with. I think we can make a difference, because remember, that's part of the placebo, is instilling hope, which I think is legitimate. And then we go into what do we think the medication might be able to do? And then you can talk about the options. Do we do a second generation antipsychotic first at low dose? Do we do an anticonvulsant first? If they have extraordinary rejection sensitivity, should we use something serotonergic first? That kind of, that then you, and then if you engage the patient in the different options and the pros and cons of each approach, you've engaged them in being not a passive participant, but an active participant in creating a therapeutic plan. And people, if a patient is more involved in that, they are more likely to adhere to treatment and hopefully to improve.
Agree. And instilling hope was the third phrase you pulled out of my head. So that's, I think, often quite the challenge. And yet, if we're not instilling hope, which doesn't mean I'm going to make you all better, it means I'm here by your side. I'm with you. I will do everything in my power. I'm your wingman. I mean, you and me against the world.
Yeah, we all have patients for whom the opposite is true. They come in and they say, you can't make me better. And the goal is to defeat the doctor. We all help projecting complainers. We all see patients like that. You know, for those people, maybe you say, you know what, I'm not sure this is going to help. And just to foil you, they'll get better.
Yeah. That's the defeat something. So give them something to defeat.
Right, exactly. But for most patients, what you and I have just been talking about is, I think, the optimal approach to pharmacotherapy for personality traits pathology.
Which goes beyond just saying, well, I'm going to look for something comorbid. I've heard some of our colleagues speak on this topic and say, well, there isn't really a pharmacology of personality, so go look for something else you can treat. Maybe you have ADHD, maybe you have PTSD, maybe you have depression, and treat it, which is fair, of course. Certainly if you have a GAD, by all means, it's just, I call that the sidestep approach. And
yeah, and that's what I was alluding to before. If all we're doing with using medications to treat patients with personality difficulties, if all we're doing is treating the associated axis 1 disorders,
yes,
then that makes it very uninteresting. And I don't think that's accurate. I think we can treat some of those core, the affective liability, the rejection sensitivity, the impulsive aggressive stuff. Those are legitimate targets for pharmacotherapy.
And treatment more broadly, indeed.
Right.
But before we finish up, Michael, I'm sure there's at least one or two of our viewers out there who's thinking, come on, just tell me what meds I should be using, because that's how people sometimes think. So in deference to whoever is out there asking that question right now, what would you say if you were doing a CME or grand rounds and someone asked that question? I'm sure you've gotten it at least once.
Yep. So, yeah, and when I do talk about this, I acknowledge that if you do a meta-analysis of studies, and there are a number of them that have been done, you come up with the idea that none of this stuff works, which I don't think is correct. Agreed. I think this stuff does work, but it's been hard to show it. And so with that as a
that said,
with that, I still do believe, both from my clinical experience and reading the papers, is that anticonvulsants may be the single best first choice, especially for the impulsive aggressive folks. For those people, a subgroup of borderlines, as you know, have kind of schizotypal elements to their psychopathology, nonlinear thinking, transient psychotic episodes.
The borderline of psychosis.
Right. And for those people, it would seem to me that the low-dose antipsychotics would make sense as a first choice. That makes sense. And it would be low dose. These are not formal acute schizophrenia doses or acute, hospitalized mania doses. For those patients for whom rejection sensitivity, somebody says boo and they take to the bed and get suicidal for 5 days. For those people, I think serotonergic drugs, whether it's SSRIs, SNRIs, or even MAO inhibitors, are reasonable first choices. So I try to, again, going back to what we said before, think of what are the dominant symptoms that are most difficult for this patient, and then try to create an algorithm among the three classes of anticonvulsants, antipsychotics, and antidepressants, and order them differently depending on that particular person's psychopathology.
I got a historical question for you. Back in the 1980s, those of us who remember the 80s, a couple of folks named Emil Coccaro and Rich Cabusi published some studies on this new class of drugs called SSRIs, looking at overt aggression and impulsive aggression. And they kind of said, funnily enough, if you have a lot of impulsive aggression, SSRIs may tamp that down. But if you have bipolar disorder, it may make it worse. I've always found that to be a bit of a paradox. In this sort of kind of dichotomy you're talking about.
Yeah, and certainly I think SSRIs do that, in that SSRIs make people less reactive, less irritable.
Yeah.
Irritability and aggressiveness are really on a continuum. Irritability is just almost a mild form of it. But if you do a meta-analysis of the studies on borderline personality disorder, the SSRIs limp into last place.
Yeah.
And you can't even show a particular anti-impulsivity, anti-aggressive effect in those studies, even though I agree with you, when you give it to irritable, depressed people, they get better. So I'm not sure I know entirely what to make of that contradiction. Yeah.
Well, to acknowledge it, and I guess in fairness, to be able to say, if an SSRI is going to go haywire on someone, it's going to have this activating effect, an over-energizing effect. It's not going to be a mellowing, calming kind of thing. It's going to be, I don't know, you're sort of getting a little bit like David Banner, ready to turn into the Hulk, and there's this brewing that goes on. Maybe the paradoxical. I'm not saying let's use SSRIs as a poor man's assay for a bipolar diathesis, but I suppose if one is going to think about, should we try an SSRI for someone with impulsive aggression, if there is a history of psychomotor activation and high energy states, that might dissuade us from that.
Maybe
in ways we didn't talk about 30, 40 years ago.
Right, but maybe, and this is going to a whole other area, I am one of those people, a la Jay Amsterdam, that really believes if you have a bipolar patient on mood stabilizers, you can use antidepressants with much less terror than the literature would suggest, especially bipolar 2s, but even 1s, as long as they're adequately mood stabilized. But that's a whole other arm wrestling match for us to have.
Well, we're going to have you back on the show and have that conversation maybe next time, because that is an important other point. So just to kind of wrap up, I mean, we want to leave our viewers with a sense of hope and optimism, but also kind of how to position things to their patients. If you've identified either there's a significant personality disorder lurking in the midst, and it is lurking, and we'd like to make it less of a lurker before we just keep throwing drug after drug your way. Words of wisdom to that clinician, how they should think about what they're doing?
If you think it's related to personality pathology, you should focus the question on what is it you want to get better, not the diagnosis, but what are the areas of symptomatology, again, the behavioral dimensions, and then target that. As you and I have talked about, for cluster B personality disorders like borderline personality, it would be impulsive aggressive stuff and mood lability stuff. And you know how to treat those descriptively, if not diagnostically, because we're talking about symptom complexes, not about disorders.
And for the patient, Kramer's view was, remember the cover of his book was like the fake face is coming off, revealing the real you. So what is the real you? So for the patient, to your comments earlier about identity, boy, how do you communicate to them? I'm going to try to surgically see if we can help take away the things you don't like about yourself.
Where you and the patient agree as to what the goal would be. What would we like to get better? Is it a bad temper? Is it that I go straight to cutting myself if I'm upset? Is it that I get into fights? Is it, right? So the patient agrees, yeah, this is a problem for me. Because if you can't agree on that,
Yep.
I mean, you better agree on that first.
That's a brilliant point, and what a great point to end on. Michael, thank you so much for taking the time out to join us today. This has been, for me, I love what I get to do here because I learned so much from my friends and my colleagues, and your sage wisdom, I think, has been helpful to all of our listeners and viewers today. So thank you once again. Hope to have you back real soon. We'll talk about that bipolar J Amsterdam antidepressant stuff next time.
Thank you for having me on the show. I appreciate it, Charles.
The pleasure's mine. And I want to thank all our viewers for joining us today. We'll see you again very soon on the next episode of Brain Trust Conversations in Clinical Psychopharmacology. Bye for now.